السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. صدق الله العظيم. I will not say more than this.
And the picture is coming only in voice. We can see you only, we cannot listen you. It's loud, so loud please.
Really? طيب, what's this? Huh? Circle. Yes. No, it's not a circle. This is short axis transgastric view in the LV. Let us make it more peculiar. You know the LV is cone. It has inferior wall, it has anterior wall and the base. I'm looking from here by the TE. So the first wall face is the inferior, then the anterior. In the screen, the first one is appearing first. I mean, if I make imaginary line this wall is inferior. This wall is, don't be confused. Not because this is inferior, this should be superior. No, there is no superior wall in the LV. It's a cone. There is no cone, there is no superior in the cone. Maybe in the square you may have it, but in the cone you cannot. So this is the inferior, and this is the anterior. خلاص? This is the LV in a different shape. Cone also. We need to divide it into 3 areas: base, mid, apical, and apex. But it has a significance because it is peculiar LAD supply. So it has a significance. So this base, how to define? By the mitral leaflets. This by the papillary muscle. And this by nothing. I mean, like this, if I told you this is transgastric short axis and ask you which level? Apical. It has nothing. It has neither the leaflet, nor neither the papillary, so it is nothing. So it is the apical. So let's add this. What's this? Male. This is the usual we use. If you get adapted with this, later on, automatically you will go with the basic, with the apical, with the apex. Don't bother yourself. They divided the LV into 17 pieces of cake. Don't bother yourself. Don't sophisticate it. Make it only at this time. And believe me, you got more than 90% of the story. Okay? So this is the mid papillary transgastric short axis view. This is the inferior, this is the anterior. Every piece of those will divide it into 3 pieces. Okay? If I said this is the RV. So if I made like this, this is inferior. This is infroseptal. This is infrolateral. Because there is nothing. This is a lateral wall. This is the street. But here is the septum and this is the RV. Again, this is anterior, anteroseptal, anterolateral. Is it difficult? Simple. Let us make it more simple, because if I jump to the head and ask him, what's this? Yes, he's still awake, alhamdulillah. What's this? Yes. This is at 12 o'clock. This is at 2 o'clock. This at 4 o'clock. This at 6 o'clock. This at 8 o'clock. This at 10 o'clock. Train your, this is a beginner, but don't be shameful. No problem. The importance is to get the issue. By any mean, I don't care. But get it in the right way. You may be at the start to be confused with the wolf, with the names. I was yesterday with one of the colleagues. I asked him, what is this? He was very confused. So 12, 2, 4, 6, 8, 10. This is nice, okay? Now I will make another thing. I will make the beam of the TE go like this. Do you know what we'll get? We'll get this. What's this? What's this? Excellent. Excellent. Do you know this mesoesophageal long axis view is expression of this beam going like this? I mean, this wall will be what? Huh? Mean infralateral. Mean infralateral. You are right. Infralateral, right?
But he right battery on this right, RB is on this side, septum is here.
Infralateral. In this one, 2 o'clock. Infralateral. And what's this? Anteroseptal. 8. This word to 8. This word to 8. I'm not joking. To remember, in the long axis, check to 8. Okay? This is infralateral, this is anteroseptal. After some time, your time will be adapted for this infralateral anteroseptal like this. We'll do the same. So this is mid-esophageal, huh? Long axis. At what degree? I will make the beam to cut this piece of cake in this direction. What I'll get? Excellent. يعني what's this? So what's this word? Not inferior? Anterior or inferior? Huh? Anterior. Anterior. So this is number 6. 6 o'clock. What this?
Inferior.
Inferior. Definitely it is inferior. Okay. Again, another beam will go like this. Will give us this. Huh? Yeah. But the drawing is bad. Imagine it is 4 chamber mid-esophageal. So This is mid-esophageal long axis at 90 at 120. This mid-esophageal two chamber at 90. This mid-esophageal, everything is there, dear doctora. Don't bother yourself. Concentrate with me, please. What is this? Huh? Anterolateral. This is what number? 4 o'clock. And this? Inferoceptal. What number? Okay. Our lecture today is wall motion abnormalities. So we start with wall. Which wall we will describe? Anatomy of the wall. We have short axis view, long axis views, and we have a correlation between them. Which one is which one in the other side? Why? Because to diagnose wall motion abnormalities, you have to check it in two views, at least, not from single view. So if you saw a hypokinesia here, you should see it here. If you saw hypokinesia here, you should see it here. Confirm. If you see a hypokinesia here, confirm it here. If you see hypokinesia here, confirm it here. You notice something? I didn't mention this one. I mentioned 1, 2, 3, 4, 1, 2, 3, 4, right? Why? I mentioned 2, 12, 6, 8. 2, plus 12 equals 14. 6 plus 8 equals 14. 2, 12, 6, 8. This is the equation I want you to come out of this room in your mind. 2, 12, 6, 8. This is your target in the OR. 2, 12, 6, 8, 1, 2, 3, 4. Again, what's the name of this wall? Excellent. What's this? No, high, loud. You ask me to be loud. Okay. I didn't mention this one. I didn't take it into good consideration. Why? Because usually we have a mixed coronary supply in this view. Not to be fair, this area in the base is LAD. This area, sorry, in the apex, I added. This is LAD, and this area is RCA. Bravo. Okay? But here we have a mix. What? No. I will tell you. This also is a mix. Okay? Type. Let's go to this one. Here, this one is, what's the name? Inferior. What's the supply? RCA. Pure, most probably. Pure RCA. What's this one? What supply? Pure LAD. This one? Anteroceptor. What supply?
Is inflow, so it will be LED or RCA?
No. Don't say or. Yes, I'm aggressive. LAD pure. LAD pure. LAD pure. That's why I take it in my consideration. Don't be confused. That's why I omit the other two. I told you 2, 12, 6, 8. 2, 12, 6, 8. Why I use 8? Unless it is pure. It is pure. 2, 12, 6, 8. 2, it is not pure. I'm sorry. This one, infralateral, usually it is CX. But sometimes going to the RCA forms. Why? You know, in the coronal circulation, there is what is meant by dominance. Circ and RCA. Sometimes the circ is dominating, sometimes the RCA is dominating. In this area, usually the circ is dominating. And don't bother yourself with this, consider it dominating. Yes, take it. But if I am allowed to myself to express non-scientific, I will tell you this is pure CX. Don't bother yourself. Don't be. لا. So we have 4 areas: 212, 68. 212, 68. Again, 212, 68. 2 circ, 12 RCA, 6 and 8 is LED. Let's go here. 2 is circ. 12
RCA.
this is pure. No soda, no water. It's pure. 6 LED. 8. Okay. You're holding the probe. I want to check the regionality. There's big difference between somebody is looking for his case in his pocket, and another one is find the case in his books. I mean, you have to train yourself for a target study. Don't be see. Okay, we have the short access, and this could be. No. Be target. Go to this area 2. Go to this area 12. Go to this area 6, 8, and then start to comment whatever you want. Okay, so this is the first part of the lecture: is wall. Clear? 212, 6, 8. 212, 6, 8. Simple. Now, what about motion? It's very simple. Either normal motion, hypo motion, or hypokinesia. No motion, akinesia. Be aware of me. I'm aggressive. And dyskinesia, which is
Paradoxing.
huh?
Paradoxing.
What?
Paradoxing.
Well, I cannot hear.
He said paradoxical.
Paradoxical. Yes. You are right. But you need another word: systolic. Because if it was systolic and diastolic, this is aneurysm. Okay? Paradoxical. Okay. It's nice. I used to make it opposite. I use the more simple terms, but no problem. So hypokinesia, normal, hypokinesia, akinesia, paradoxical or dyskinesia, and aneurysm. How to differentiate normal from hypokinesia? Akinesia we can differentiate. It's not moving. خلاص. But normal and hypokinesia, this is a dancing area. It's a gray zone. We need a specific thing to determine, is it hypokinetic or normal? Excellent. Huh? What? ما في بس you are right. Thickening will be a determination for this, and it's only 2 tools to have this. We used to do the excursion. Excursion means when you see, imagining a central dot here, and you see how this wall is moving to this dot. And يعني it's subjective, by the way. يعني you may say, okay, it is hypokinetic. No, it's normal. So what can make a conclusion? Thickening. What is thickening? Suppose this is this is M mode cutting the anterior and inferior wall. This is the inferior. This is the anterior. Okay. This is diastole. This is systole. In systole, thickening is increased, right? Normally, it should increase more than 30% of the diastole. So if this diameter is 5 mil, 30% means 1.5. So this one should be more than 6.5 to be normal. If it is less than 30, this is hypokinesia. What grade of hypokinesia? Mild, moderate, severe? Because from 10 to 30, this is hypokinesia. Below 10, this is akinesia. Thickness, I'm talking about thickness. So if it is 5, for example, this is hypokinesia. خلاص. More. If it's 5.5, 5.5, it's يعني almost near to akinesia. If you see this wall, what happened here? You see any systole or diastole or something? This is a kinetic inferior wall. Due to what? This is a kinetic inferior wall. Due to what? RCA what? Yes. So we have, we made the thickness, we made the excursion. Another point in the thickness, which is tethering. In such a patient with inferior wall akinetic, it will be built by this wall and this wall. So you imagine that this wall is moving. It's not moving, but it looks like moving due to what's called tethering. It's pulled down with those monormal walls. To differentiate by M mood again, we'll give you the story. Is it moving or not? Okay. So we have the wall finish. We have the motion finish. We have the scan. Scan also finish. 21268. Okay. Why we are doing all of this جرجر؟ بس عشان انا مش شايف. ماشي، انت اللي قدامي يا عبد الله. لا ما تخافش. I have the honor to work with Dr. Abdullah, our new fellow, smart fellow. I worked with him this week and last week, the week before maybe. We are in baby lab. He wanted to report me the case. He told me this patient is blah, 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 and his ejection fraction is 50%. He has a good systolic function. He never mentioned anything about regionality. Absolutely. And wait, I even didn't ask him, what about regionality? It means that neither him or me are interested in regionality. All of us are interested in Dr. Ibrahim, ejection fraction. Okay, this is true. Nobody can ignore this. We are doing this in our practice. No one going to, what about the regionality? Who is hypokinetic? Who is akinetic? Who is... So why are doing this? Well, it was tough to me to wake up this early morning. So what is the benefit of this gurgle again? Let me tell you some stories. This is true events. It's not a fake stories, by the way. This is true events. And thanks God, we have a surgeon here. It was a case of mitral valve replacement. Patient come off. Dynamics are borderline. I start to increase the inotropes. I ask to check with the volume. Is the patient responding to volume or not? It's not responding. Still dynamics are borderline. I escalate the inotropes. Still the dynamics are borderline. I look at the TE. Check. I found this area is hypokinetic. Area number 2. Area number 2 is hypokinetic. I cannot report this. I wait to confirm it here. Area number 2 is hypokinetic, really. So I start to prepare myself to give the surgeon this red flag in his chest, telling him that this anterolateral wall is hypokinetic. It's like a red flag in his chest because he knows what it means. In other words, it means what? Circumflex is disturbed by some way. And he had nothing to do except either to remove the valve and reinsert or to put a graft on the circumflex. And it happened with a famous surgeon. I don't know, did you attend with Calfiori? It happened with Calfiori. Here we have this famous Italian surgeon there. Is it magic? Is it dream? The key was regionality. Regionality is the thing who discovered this and redirect the surgery to another way. Okay?
How was the injection tracking at that time?
Well, I don't remember and I don't care. You have a problem. You have a regional problem.
Yeah.
It's a mess. We're still in mitral valve replacement. Again, the same scenario. Dynamics are borderline, not responding to filling or inotropes. This time you look at the TE and you found this area. It's hypokinetic. You want to confirm you were here. It's hypokinetic. Why? Any explanation? We are in the mitral. We didn't go to the right coronary at all. We are in the mitral area. Air. Excellent, Dr. Fatma. Air. You know, if you stay in the OR for 1 week in the OR, you will find this once, at least per week. You saw it yourself? Because you are not in the OR.
Late duties, PET scan.
Yeah. Yeah, subhanallah, like the tube, when we go more deep, it prefers to go to the right bronchus because the anatomy orientation is like this. Air in the heart, in the aorta, when it goes to prefer to the right coronary, fortunately enough. Otherwise, we will have a big trouble. If you go to the left, go to the right. Usually, you saw this. This week, I spent 20 to 30 minutes to make deaeration. Deaeration is very important. Okay? So air can do it. What is the treatment? You will just increase the pressure to allow the air to be go more distally until it is spontaneously absorbed. Air is really common. You can see this. قلب أتعبه الهوى. Hawa in Arabic means air or love.
This Hawaii you do us.
So heart get tried with Hawa, either air or love. It makes double meaning. I will tell you later. خلاص, mitral replacement, aortic replacement. Aortic replacement after the finishing the surgery and we are coming off and dynamics are borderline again. Again, not responding to filling, not responding to inotropes. You check You check here. 212.68. 212.68. You found this 12 is again hypokinetic. And you confirm it here. You report it to the surgeon. Surgeon, okay, this air, it will be resolved. Okay. Just increase the pressure to allow the air to be absorbed. 5 minutes, 10 minutes, the heart is getting more worse and no air is absorbed. What happened? He knows what happened. He knows, huh? Excellent. But you know the story? When you insert a radial line, and it was difficult. It's not easy. Sometimes it happens. When this line get disturbed later on, you know, it was not easy line. It's the same when you're telling the surgeon, we have a problem in the inferior area. For example, severe aortic stenosis, aortic annulus was tight. He was, what to do? To make aortic root dilatation, or it's okay, this size will be enough. So he insert oversized valve. And this oversized valve, he thought it may be okay. It may be matching. It was not. And it was stretching this area, the RCA, which affected here. The only solution in this way is to remove the valve. He has to go and bump again to remove the valve and to insert a new one, either to make a aortic root dilatation or to with a smaller valve. The problem in smaller valve, he will make a gradient also. He came to the art to decrease this gradient. He will have a gradient. So it's better to have aortic root dilatation. Anyway, and this is a surgical decision. But the whole story started with regionality. This mess for the surgeon. And of course, he will blame you or blame the ICU. But he صح يا شريف؟ بالظبط كده. He will blame anyone except himself. By the way, Dr. Ibrahim talked about the global function. I'm talking about the regional function. Which one is the good news? Which one is the bad news? No, I'm asking global and regional. Which one is the good news? Which one is the bad news? Huh?
Regional, you can restore it.
Yeah. Global, usually due to causes that you cannot treat. Stent myocardium, poor protection. What you will do? You escalate your inotropes, and then it's not working. You add mechanical support like intra-aortic balloon or ECMO, and you will stay and pray. And you will send the patient to the ICU and ask Dr. Sheikh Ibrahim to go there and stay and pray. But in the regional hypokinesia, there is a specific reason. I gave you the examples. There's a specific reason, and usually it is iatrogenic, and usually it is a surgery.
Usually it's
The last example, because we take 1, 2, let's take those. Cabbage. Every day we have cabbage. Okay, come and go bump, patient is not good. We have a problem. You check, you found this 6, 8, or both are hypokinetic. We have a problem. 6, 8, anterior and anteroseptal. Anterior anteroseptal. I didn't get here. That's why I'm concentrating in these areas. 212, 6, 8. You report this to the surgeon. He knows. He knows that anastomosis of the edema to LAD was not good, was not optimal. Or the area, the target area he chose to make the anastomosis was not optimal. There is nothing to do except going again on bump and do a new anastomosis. This is all directions happen by what? Regionality. Regionality is very important, especially in the post-bump time. may you say, and for you as a cardiac anesthesia, it is only important in the post-bump time. Best. And post-bump time is the most critical time in the cardiac surgery. خلاص. So you may tell me that 6 and 8 was bad before, dear doctor. Why you suppose that this is improper anastomosis? I tell you, yes, you are right. That's why you have to scan the patient in the pre-bump time. Scan your patient and these four. I'm happy if you do it in these four. 2, 12, 6, 8. Scan your patient, have a baseline, and then in the post-bump time, you can build up over and see is there any change. That's why when we saying Rwma, regional wall motion abnormalities, it's not only this. New regional wall motion abnormality. New. If you have old, خلاص, I will not build up over. خلاص. But you have to make a pre-bump to have a Rwma, and in the post-bump, you have N Rwma. Okay? Let's start lecture. The problem in the lecture, one thing, name of the walls. You are always confused with this. We solve one area, but we didn't solve this next area. We solved this first area. All now, inshallah, are knowing. This is inferior, this is inferior, this is anterior, and we divided it into 3 parts. We said this 12 o'clock, this is 2 o'clock, this is 4 o'clock, this is 6, this is 8, this is 10. Instead of saying infro, antro, and this is confusing names. The thing I forgot to tell you, in the longitudinal, this is RV, this is a long axis, and this is the 2 chamber, and this is a 4 chamber. Here we mostly confuse which of which. This is what, and this is what. If we have 2 chamber in the view only, this is a simple name. Name, what I mean simple name, one word, inferior, anterior, anterior, inferior. If more than 2 chambers, it is compound name, anterolateral, inferior, like this. The same like here. Look, the thing I forgot to tell you, your right hand is anterior, always. Your left hand is inferior, always. So if I'm going here, my right hand here is anterior. My left hand here is inferior. Here, anterior. But it is near septum. So anteroseptum. This is my left hand is inferior to the street. So infrolateral. Here, this is my right hand is anterior to the street, anterolateral. This is my left hand here is inferior. So this is infroseptal. Why you are laughing? طيب خلاص. So right hand anterior, left hand was inferior. As like sunnah. Right hand, anterior wall is more important than the inferior wall. So the anterior wall is the right hand, the inferior wall is the left hand. That's all. Let's go now to the view. دكتور ابراهيم، خليك عشان تكبر الصورة. طيب. I don't know.
انت عايز تعمل
عايز احركهم. دي انهي This is what is the original roll motion here? تمام. How to do next? Like this? Yes. Here.
Like global.
Excellent. Hmm? Hmm? Infroceptor. Only? Let us review again. You remember here the most important words 212.68. 212.68. Okay, where is here? Huh? 12.68. Why? 68? No. 68 is normal totally.
It is sticking at 6 8. It's normal.
Huh?
6 8 is thickening, so it's normal.
Excellent. This is huh?
Two
Huh?
and
It's clear that area 12 is not moving or very, very little. This is inferior. Okay? You can add area 10, infroceptor. Yes. How to confirm? Please, because somebody upload video of short axis view and start to comment in the previous week. He start to comment of hypokinesia on here and there. He has two mistakes. I didn't comment. What? Excellent. No, not two views. Short and longitudinal. Short and longitudinal, here and there. We said this and this is the most important for us also. 1, 2, 3, 4, 1, 2, 3, 4. So you need to comment again. If you got hypokinesia in the short axis, you need to confirm it in the longitudinal axis. Another thing, if you want to confirm your original motion, to do what you said. You said, Mr. Bala, Dr. Bala.
yes, sir.
You said, if we want to confirm, we need two confirmation. The first is the longitudinal. The second is thickening.
Thickening.
He didn't take M mode for the area to show if there is systolic thickening or decreased systolic thickening. To confirm this is a big word to say this is hypokinesia, this is akinesia. You need to confirm. This you have to use the short and longitudinal and the thickening. خلاص؟ It's arrhythmia. Don't be confused.
Please.
Basing, actually, the basing usually regular. This is not regular. This is irregularity. But what about the Rwma, regional roll motion abnormality? Rwma. We have N Rwma. Yes. Yes. Excellent, Dr.
Yes, 8 o'clock.
Yes. Acute LAD. Yes. We said we choose these four areas because it is mostly peculiar for the specific coronary artery. Area 12 clock is RCA. Area 2 clock is left circumflex. Area 6 and area 8 are peculiar for the, yeah. Here. Huh? Akinesia. Akinesia. Where? Where? We are repeating now. This is difficult, yes. It shows scar in the inferior area. Basal inferior area. Huh? Eh? بص معي. بص معي. Very clear here. The advantage of this slide, it shows what we are saying. We need to take in the longitudinal and in short axis. Don't comment on only short axis. You need to comment on two views. We said don't comment.
This kind of thing. The
Let us check it again.
ball is moving outwards.
During systole, the basal area is going to the other side. Notice this.
Yeah,
Notice this.
not
Here, unfortunately, the gain in the inferior part is not clear.
Here is
What is this view? Anyone can notice? Excellent. Yes. What's this? Huh?
One more. We have one more view.
He's smart.
To comment.
What's the name of this wall? Huh? Anterior interceptor. It's LED. Yes. Interceptor. This is easy. Hmm? No, comment on the Rwma. Yes, yes. We are here to comment on the Rwma, not to etiology. Etiology in your mind, in the field of the surgery. Yeah. Huh? This is Dr. Galal now. Area 2. Area 2. Infralateral. Now we want to go on bump again and repair what we did. Now see how the difference. Thank you.